his first one, but I pulled off, the VA has put out a series of patient stories. I pulled about 3 of them for patients who have Parkinsonism. One is on dyskinesias, one is on impulse control. So when you use dopamine agonists, they're very effective, but people lose impulse control. So gambling, risk of increased gambling, eating, usually hypersexuality, those start to manifest themselves. So there's a really good story of a couple who talk about that and what happened to them. And that's under impulse control. It's a separate one. And then there's 2 that I put out on dyskinesias. And they're the drug-induced dyskinesias. One is really good with an older man. The other one is a younger woman. She's probably early 40s, and she has early onset Parkinsonism. So I'm not going to play those today. I'll post this, and you can look at them at your leisure. I think they're really good because you get the patient's story. You usually get the wife's story and how it affected her. These are about 8-minute vignettes. And then you get a physician and a pharmacist and usually a nurse who also works with that patient. That gives you other sides. So it's really a very nice visual, I think, and also can help you to understand how it affects their life and how the drugs help or cause trouble. So I'll post these after class. But I'll play you this one. This will kind of give you an idea of what they're like. They're well done.
While I was at work, I noticed that I was sitting at my desk and, I was going to the computer and all of a sudden the pinkies just started jumping up out of control and I couldn't stop it.
It's very hard for him, he tries, but when he's off meds, he can't really interact too much with people.
And so I had to, quit my job, because I couldn't perform, at 100%, In the Veterans Hospital, I went back in the year 2000, and they diagnosed me with Parkinson's, and they started me on medication.
Well, Parkinson's disease is primarily a deficit of dopamine in the brain.
Dopamine is a chemical messenger in the brain that can affect movement.
Levodopa is what we consider the gold standard drug in the treatment of Parkinson's disease. It has the best effect for the motor symptoms of Parkinson's disease with the least amount of side effects compared to the other drugs.
So what levodopa does is it actually helps replace the dopamine that's missing in the brain.
We use a simple analogy of either being on or off. When a patient is on, that means they've taken their medications, the medications have kicked in, they're starting to feel the benefit from the medications, and they feel some improvement of their Parkinson's symptoms. And when the medication wears out of the system, they start to turn off, meaning that the medications aren't working as well, their Parkinson's symptoms are more prominent.
And, if I don't take my medication, the tremor starts,
On the other hand, Mr. Gomez, in his off state, he has more Parkinson's symptoms, and for him, this involves mainly slowness and tremor. You'll notice that he has more tremor on the left side of his body, particularly in the left arm.
Off state, his tremors are there, his stiffness is there, he's unable to lift his leg and walk normal, his stuttering is there. It's very hard for him.
If you don't mind doing it one more time, just turn around and go back to the other side.
When he's on the meds, he's able to function. The tremors subside.
Just go back toward the eyes. Right, it seems a lot better than before.
He's able to walk a little better, he can lift his leg a little better, and he's able to speak clear.
Same thing one more time, just go back to the In Parkinson's disease, there is a problem with the medications that we find that we can't keep them at a steady level in the bloodstream throughout the course of the disease. Actually, earlier in the disease, it's easy because the brain is able to take up and store the medication that we give them, so we can get away with giving the medications a few times a day. and the dopamine is released at a constant level through the day.
Over time, as the Parkinson's disease progresses, you will find that symptoms wax and wane. Where you were getting benefit for a full 4 or 5 hours from the medication, you're no longer lasting that entire time after you take the levodopa dose. It's because of the fact that the disease itself is progressing.
So our goal in Parkinson's is to keep those levels as constant as possible so that the patients can have continuous symptom relief through the day.
Levodopa itself does not affect the progression of Parkinson's disease. It purely helps to treat the symptoms.
Patients frequently need medication adjustments in Parkinson's disease because this is a progressive disease. As time goes on, the types of medications that people need and the dosing frequency and schedule change frequently. So I usually address this at every visit with patients, and often every 6 months or 12 months we're making a medication change.
It's very important that patients take their meds exactly how they're prescribed. If you skip a dose or miss a dose, the medication's going to wear off, and then you will have your Parkinson's symptoms. As time goes on, it can get harder to get the patient back into that on state where the medication is working if they've come off of the drug and they're having really bad symptoms. It just gets more difficult to control as the disease progresses.
Well, there's several strategies to keep up with medication regimens. One is to have a fairly strict schedule with medications.
A pill box is really key to sort of keeping yourself organized. It helps take the guesswork out of, did I take my medication? Did I not take my medication? Because you can check inside the box and see that it's gone.
About 6 times a day I take my pills. I take about 30-something pills a day. Not just for Parkinson's, but for other things I have, you know.
Well, Mr. Gomez has a more complicated schedule in that he has to take the medications every few hours.
My wife's the one that knows all my medicine because she's the one that keeps track of them.
There's so many that he doesn't know what is for what. I try to set it up daily or every 2 days.
In the beginning, he could take them every 4 or 5 hours, but we found that his medications became shorter in duration of the effect every time he took them, and so we had to shorten the interval to every 3 hours. This is typical of the more advanced Parkinson's patients where the drugs just don't last as long in the system and you have to give them more frequently. Unfortunately, there are side effects to every medication despite how good the benefits are. Levodopa has the least amount of side effects typically of all the Parkinson's medications. The ones that I warn people the most about when they're starting the drug are nausea, which is probably the most common, an upset stomach.
It can also cause some other adverse effects like agitation, confusion, dizziness. Those more often happen when you're on a little bit higher of a dose of levodopa. If those types of side effects happen, we usually tell the patient to make sure that they talk to the doctor because there may be some adjustments in the medication that we can make to help reduce those types of symptoms.
Well, there is a complication of the medications that are used to treat Parkinson's disease called dyskinesia. And we think of this as a side effect of mainly the levodopa. It's a symptom where you get extra movements superimposed on top of the normal voluntary movements. And so the person can appear as if they're restless or moving around excessively, or sometimes they can have muscle spasms as part of these movements.
But but if I take too much, I get wild. I don't know if you've ever seen, Michael Fox, how he moves, I get like that sometimes.
One other important thing to realize about the medications is that everybody has a different response to them. So Parkinson's disease is a very individualized disease in that everybody is affected differently by the disease. In the same way, everybody reacts differently to the medications.
I enjoy playing congas. I used to play it, before I got sick. When I take my medication, it makes it a lot easier. So it helps me a lot, And we sound pretty good, I think, people stop listening to us, so I guess we're playing, well,
I just would like to see him last, to spend time with his grandkids, to be able to walk his daughter down the aisle, to be able to see her be 16.
They want a better quality of life than what they got right now. Take your man, and enjoy life. You know, because it's not the end of the world. That's my advice, you know.
All right, on page 7, I've just given you definitions there because in the text, it will refer back to tremors or dyskinesias or achinesias, dystonias. These are just simply things for you to refer back to. I'm not going to test you over them. In terms of the next page, we can divide the treatment of Parkinsonism into drug therapy is the mainstay, the pharmacologic agents. There's non-pharmacologics and there's surgery. I'm only going to focus on pharmacologic, the prescription items. We can also divide the drugs into those that are neuroprotective and those that are symptom control. All the drugs that we will talk about today are for symptom control. Some of them are also neuroprotective. So that would be mostly levodopa and the dopamine agonist are considered neuroprotective. None of them will change the course of the disease or the progression of the disease, but they may protect the neurons for a period of time so the person is more symptom-free, more functional. Decisions to treat there come down to when is the person encountering enough effects of the Parkinsonism that affects their daily life. So it's very individual. So it's hard to just say this is the point, but if the effect of the disease in the dominant hand so that their ability to do things for themselves becomes impaired, social living, you can see that even though he's fairly advanced, he was fairly functional. To be able to play that drum at the end I thought was impressive and hopeful. Significant bradykinesia, so usually that comes out in their walking, their shuffling, and their risk for falls then become a worry. The non-motor features such as cognitive impairment, their depression, fatigue, sleep, their ability to interact socially goes a lot to the fact that they get very kind of emotionless faces, blank faces, or they don't eject or project a lot of emotion, and so sometimes that can socially impair them as well. Our goals of therapy with drug is to maintain motor function and not only function but good function. Also the ability to preserve activities of daily living, improve mobility. You heard some of those things that they talked about. So what did they hope for? What were some of the things the wife mentioned at the end and that he mentioned?
Grandkids.
Grandkids, walk his daughter down the aisle. His ability to play in his band, what, Lauren?
See his other daughter turn 16.
See his other daughter turn 16. So those are really good things to know because they can be good motivators that you can use with them. Minimize adverse effects, those can be sizable with these drugs, significant. And then the complications of treatment as well. So the major drug classes are listed there for you. Levodopa is considered the first drug of choice in most people. You can use dopamine agonists as well as a first choice. Usually we use those in younger patients. Every patient will eventually need levodopa if they live long enough with the disease. So even if you start a dopamine agonist, there will still come a time when you would need to give them levodopa. The monoamine oxidase B inhibitors and the COMT inhibitors are drugs that inhibit the enzymes that degrade dopamine. So those are usually adjunct. They are rarely used at monotherapy. They can, but they're just not as effective in terms of keeping dopamine levels up, so they're often added to. Amantadine used to be a fairly common drug used in Parkinsonism, but now we have better drugs, and that drug is more toxic in older people, so it may be used in younger people with fewer motor symptoms. The anticholinergics, again, because Parkinsonism usually is a disease of older adults. You remember those are on the Beers criteria. So we like to avoid those because they can increase the risk of dementia. But in patients who have persistent tremors or only tremors as their symptomatology of their Parkinsonism, sometimes they will use those as a very focused treatment. They can use them as adjunct if you've got a tremor that doesn't respond to dopamine or levodopa or dopamine agonist. So more limited. So your two mainstays, levodopa, dopamine agonist, and the other two that are adjunct, and the other two that are much more specific, depending on what the patient's experiencing. So it's at the bottom, levodopa, most effective, first line. When patients become akinetic or bradykinesias, that's when you would use those drugs. This is just kind of some, the next page, I think I did most of these. These are just kind of summaries. So let's move on to page 10. We'll talk about levodopa. So levodopa is an immediate precursor to dopamine. So it gets metabolized to dopamine. Levodopa is first line because it can cross the blood-brain barrier. Dopamine cannot. So that's our way to get dopamine into the brain. And it concentrates in those cells that are in the substantia nigra. So early in the disease, this drug works really well because you've got enough synapses that can store up the dopamine and use it throughout the day. So what they were talking about, those on-off, those on times are when you have enough dopamine present that you can keep the body functioning normally. What happens over time is you lose those cells in the substantia nigra, and so the ability to take up dopamine, to store it, and then use it throughout the day goes down. The half-life of L-DOPA is pretty short, it's like 90 minutes. So in the fewer and fewer nerve terminals that you have to store up that dopamine and release it, the less likely you'll have enough dopamine to prevent those bradykinesias from occurring. So that's what they were talking about on-off, and that's why as the disease advances, you have to give the drug closer and closer together. So when we start off, we are usually giving the drug, like levodopa, twice a day. But you may get down to where he was using it every 3 hours, and that's because of the loss of cells in that part of the brain. Make sense?
Do you run the risk of downregulating the dopamine receptors by using too much?
Not that I have ever read. So I don't think so. And I think it's just because it's a progressive loss. So I think it probably that just doesn't kick in or becomes a phenomenon that I've ever seen. Good point though, because we brought that up multiple times. If you look down at the bottom, initiating dopamine agonists, again, younger patients, under 65, over 65, go ahead and use levodopa. You can use levodopa anytime as your first line. So this is in your handout. So this is the way we're taking in the drug is the levodopa. This dopa decarboxylase is an enzyme that converts levodopa to dopamine. We don't want that to happen in the periphery. So we use another drug called carbidopa that doesn't have any pharmacologic effect except that it knocks out that dopa carboxylase. What that does is it allows levodopa more concentration in the periphery, it moves into the brain. So it keeps it from being peripherally metabolized to dopamine, and it gets more of it into the brain. So that's why that carbidopa is up there. So that leaves dopamine moving into the brain or levodopa moving into the brain where it can then be converted into dopamine. Formulations. So this is on page 12. So we don't use levodopa by itself. We always use it in combination with carbidopa. So it comes formulated that way. Sinemet, it's been around forever. It comes in these standard fixed combinations, either in a 10-to-1 or 4-to-1 ratio. These are considered immediate release. We start with immediate release because we can get more symptom control. Using controlled release is too slow. We don't get enough peak out of the drug, and so it's just not as effective. So we will always start with an immediate release product, and then once we've stabilized the patient, we'll move them to a controlled release. And the controlled release you'll see is usually in about a 4-to-1. So by having this type of flexibility, you can match it to the patient's response. The next picture is just, we've gone over it just as another way of looking at it. It kind of shows you a little bit better about the carbidopa, the L-dopa moving into the CNS with the action of the carbidopa. So it's a little bit redundant. It's just, I like the picture better. Okay, so dosing levodopa on the top of page 13. We start with small doses. You heard the doctor say the the thing that causes patients the most trouble in the beginning is the nausea. So starting with low amount of dose and titrating it up. You titrate it until it gets the effect you want. So you're looking more about the patient's ability to move around, the tremors, their ability to do like to walk without tripping. So that's what the titration endpoint is. And that can take days to weeks to get it up to that dose. Tolerance, you advance the dose based on how tolerant the person is of the drug. So a lot of it's that nausea. Giving it with food helps. It helps just slow down the rate of absorption, and so they do a little bit better with food early on. If you look at that dose titration, it kind of gives you a guide that most people in the levodopa amount, total daily dose in the range of 300 to 600 milligrams a day is where most people will fall. It also, there's a note there that says if you're getting up above 1,000, you need to reconsider your diagnosis. Probably it is something besides Parkinsonism. Let's look at the kinetic differences. Again, start with an immediate release versus a controlled release to control symptoms. The controlled release is less bioavailable than the immediate release. That's another reason to use the immediate release first. So the controlled release is about 70% bioavailable compared to the immediate release. Once you get a person stabilized, though, they will produce the same effect. So they're equally effective. We just use the kinetic advantages of the immediate release early on, and we use the kinetic advantages of the controlled release later on. Managing nausea, again, with food helps in the beginning. The other is that you can use supplemental doses of carbidopa. If you have a lot of nausea and they're not responding, or they're responding to levodopa but they're having lots of side effects, you can use more carbidopa. It does come as a single agent. Or you can use antiemetics as well. Later in the disease, especially the gentleman that you had in the film, when you're having to dose the drug very frequently, is then you want to give it on an empty stomach. Because then you get around the stomach, or around the effect of food of slowing down absorption. So this is one where a lot of pharmacists work in this area just because of the need to adjust medicines individually and based on these factors we just talked about. Page 14, there is a syndrome called Parkinsonism hyperpyrexia. We'll talk about this when we get to site. Is you can get a neuroleptic malignant syndrome. It is a medical emergency. The reason it's rare, but if you get it, your risk of dying is fairly high. Mortality is high with it. They get a very rigid, they get very spastic, their temperature can go up very high. They get an autonomic dystonia, so blood pressure goes up, their autonomic nervous system just does not work. So many manifestations which can kill them. So this is one that can occur with Parkinsonism when you're using levodopa. The thing to communicate to patients is do not stop your drug abruptly. This would go for when they are also going in under procedures where they're NPO or they're under surgery. So here we've got IV formulations we can use. So we use apomorphine as a rescue medicine or as a replacement until they can take PO again. Adverse effects. So nausea, most common, other increased sleepiness, dizziness, headache, those are common early on. Usually they go away with time. The more serious are, and these are more common in older patients, are the more side effects, so confusion, hallucinations, delusions. They will tell you very interesting stories about people in the room and what they're doing. And I have found often they will know that it is not right, but they still see it anyway. So agitation, psychosis, all can occur. I want to talk about the orthostatic hypotension because of all the serious ones, that's probably the most common. So they will often have a significant orthostasis from moving from laying down to sitting up or going up to standing up. Warning them about it is important. Sometimes you can do dose adjustments or adjustments of formulations to get around this, but it can be a significant. So if you've got somebody who's already got some bradykinesia and maybe has gait imbalance or disturbance, and then you put this on top of it, the risk for falls is very high. So talking to the patient about how to move from laying down to sitting up or standing up, having assistive devices around, warning family members, having things in the shower or in the bathroom to where they can assist themselves is important. Then we have questions about those. Okay, motor complications of levodopa. So they alluded to this in the film about the motor fluctuations, the wearing off of over time of the levodopa's effect is one of them. Involuntary movements he alluded to, the shaking, can't control it, the dyskinesias. I'm going to talk about some that we can kind of categorize and what do we do. Very, very common, and it's more common the longer they've had the disease. And this is thought to be just due to the progressive nature of the disease and the loss of that part of the brain and the wearing off of the drug over time. So if you'll look on page 15, here are the 4 that are most common, and we'll go through those individually. And one of your objectives is what do you do? So that's what I've got down in that table is important to know. If this occurs, here's your action. So the end of the dose wearing off, the motor fluctuations, this is increasing frequency of the drug. Or adding a drug that will keep it around longer. So this is where you can add one of your enzyme inhibitors, either your MAO-B inhibitors or your COMT inhibitors. It'll keep the dopamine around longer. Off periods can occur at night. So patients go a long period of time in sleeping, then they can wake up in an off period. So sometimes you can do some of your dosing at night that would allow them to wake up in an on state. The delayed on or no on, there is where you would give the drug on an empty stomach. There's also some of these products come as orally dissolving tablets that just are faster in onset. Avoiding the controlled release. Having apomorphine around that you can use as a rescue could also be used, since it's a parenteral, has very fast onset. The freezing is it's just what it says. They can't move. They could be standing up and trying to go forward, inability to do so. So here the remedies are to, again, give it on an empty stomach. Crushing, what they're talking about when they're chewing or crushing the product is just to get it into the system more rapidly. Please talk to the pharmacist before you do that. Make sure it's a dosage form. If you're instructing the patient to do that, that won't ruin the kinetics of it. So if they've got a controlled release, there's no reason to do that. We can switch them to an immediate release product to where they can get it in their system faster. And then again, that apomorphine as a rescue drug. The other, if you look up in the chart, it's using your other products, your other adjunctive enzyme inhibitors, the assistive walking devices so they don't fall, that can help. I'm not sure about the sensory cues, the rhythmic commands, the stepping over objects. I do not know exactly what those entail. It was part of the recommendation, so I apologize there. I'll talk to Maria and ask her what those are and send them out to you so you have them. Did your ClinMed person talk about those? Did she say anything about them? Did she talk about utilizing a physical therapist as part of the therapy? Did you all talk about that? Yes? The last are peak dose dyskinesia. So this is where, he talked about in the film that when he takes too much, he has side effects that cause motor movements that are not voluntary. So here it's using a smaller dose so you don't get as much of a peak. So you may be having to dose it more frequently to get less of a peak. So there's peak effects, there's duration effects, that you can manipulate the drugs that you're using to help those. They'll often have them keep a motor diary of when symptoms occur and what is occurring so they can figure out, is this a peak effect, is this a duration problem for the patient. On the next page, page 16, there's the off-period dystonia, so just a different type of motor dysfunction that occurs. It's usually lower extremities. This is a pretty good picture of it. The clenching of the toes, the turning end of the foot, usually occurring at the end of a dosing period. So getting the medication back on usually will relieve that. Here's where botulinum toxin comes in, a more specified or focused therapy for it. The dyskinesias, again, is those peak times, so knowing when they're occurring in relationship to when the drug is taken is important. So lowering the dose. Some will add amantadine at this point to help with those dyskinesias. Questions about those? These patients are going to be followed by neurologists. So I think unless you're in neurology, you're not going to deal with a lot of this. But what you will deal with, what I've seen at least in family medicine, is we dealt a lot with the orthostasis and more of the side effect profiles. Or in adherence, or getting them back in if something happens, or neurology can't get them back in. So dealing with some of the dosing dyskinesias we would deal with. And the side effects. Okay, dopamine agonist. On the next page, a wide variety here. Bromocriptine, you've heard of before. We talked about it with growth hormone, acromegaly. This is a centrally acting drug. We also can use it in diabetes. It's one of the lesser used drugs, but certainly has effects. The next two, Maripex and Requip, are oral agents. There is a patch, the NeuroPatch, Nupro patch, and then the apomorphine. So there's a lot of different drugs in this category, and they have different dosage forms. So it gives you a wider variety of ways to address individualized patient needs. The dosing, under dosing, these require frequent dosing, just like we'll see with the levodopa in terms of like 3 times a day. Transdermal is a once-a-day patch, and you can titrate it on a weekly basis. The apomorphine is a subcutaneous. It's used mostly as rescue, or if a person's got to be off drug for a period of time, NPO, you can use it as a more continuous fashion. Again, dopamine agonists, just like the levodopa, you do not want to stop abruptly, so making sure patients and their caregivers understand that. They can have a withdrawal syndrome that is just like we saw with the levodopa, so that's part of that more serious. Under common, it's very similar to what you'll see with levodopa in terms of the nausea and vomiting, orthostatic hypotension as well. They're less common but more serious are impulse behaviors. So these may be behaviors that they have that are normal in terms of just daily living, but they become accentuated with these drugs. One of the films that I've got in the PowerPoint is a man that when he goes on the dopamine agonist, he becomes hypersexual. And he said, usually on a regular, usual life, I have sex twice a week. But he said, it's really cute because this couple is older, and to listen to the wife talk about it, and she's Southern, so she's very diplomatic, but it's just a great story. He got to where he wanted sex all the time. And so they said, we knew something was wrong. So they worked with the drug, and they're very frank about it. So it's very good to listen to. But gambling, eating can be overeating, or habitual binging can become a problem. So that's fairly unique to this class of drug. So warning the patients about that. Also, the doctor in the film talks about encouraging patients to talk about these, because he says usually it's behavior that people will hide or will not want to discuss. So encouraging them to be frank about it so that it can be addressed. And he talks about once they adjusted the drug, his behavior went back to usual. So it's not something that they are forever changed. Let's see. Questions about the dopamine agonist? So the important thing here is that you be able to identify which drugs fall into this category, and their place in therapy, also their unique side effects, and their need for multiple day dosing, and that they can be used monotherapy. That picture that's on the top of page 18 is more, I liked it because they give you all the different places where the drugs are working. So it shows you where the COMT inhibitors are working both here and here. One of them only works both peripherally and in the brain. One only works peripherally. The MAOB inhibitors, the dopamine agonists direct on the dopamine receptors, and then the levodopa. So kind of look at that one when you're looking at mechanisms of action, so you can start to see, and it also starts to make sense why we would use drugs with these multiple actions. So the MAOB inhibitors, I was trying to think if we use these any other place, and I can't think of any other time we use them except in Parkinsonism. There's 2 of them. There's selegiline is the oldest. It's been around for a number of years now. And the other one is rasagiline. It's a newer one. They have some major differences. Selegiline, the major problem with it is that it gets metabolized to an amphetamine. So the side effects are associated with that would be hyperactivity, also weight loss because it's an anorexic, and then blood pressure can go up as well. It shows you insomnia, hallucinations, jitteriness. The rasagiline is a second generation. It does not get metabolized to methamphetamine. Is it methamphetamine? Yes, methamphetamine. So it may be the preferred, probably more expensive, but is certainly less problematic to use. And it has one other. It has a no, I'm thinking about a different drug. So those are kind of the pros and cons. So these are adjuncts. They may use them early on, mild monotherapy, but they're not very effective that way. So mostly as an adjunct. If you look at the top of page 19, this kind of shows you what happens over time. This is normal dopamine levels in Parkinsonism. This is MAO, the activity with normal aging goes up, so dopamine levels are going to go down normally. And it shows you when you inhibit that activity, that enzyme activity goes down and your dopamine levels go up. So just a nice visual. The anticholinergics, again, I said these have a very specific and focused use in Parkinsonism, mostly with essential tremors. The problem with is dopamine levels go down in the brain, acetylcholine levels go up. So in the past, these drugs were probably used more frequently in Parkinsonism. Benztropine and trihexylphenadiol are the ones that are most commonly used. The side effects that you know about with anticholinergics are all consistent with these two drugs. All the same contraindications, the same effects with men in BPH or in patients with closed-angle glaucoma. We don't want to use them in older patients. So those older than 70, you really want to avoid those. Because of the increasing risk of dementia. So younger patients, mostly essential tremor that either doesn't respond to the others or is the only symptom they have. Amantadine, an old drug, again, not used that often, only an add-on in patients who don't respond or can't tolerate other agents. Again, in younger patients, is effective on tremors and the bradykiniasias. Adverse effects on the top of page 20, confusion, dry mouth, hallucinations, nightmares. So you see this a recurrent theme. It's because you're changing the balance of those neurotransmitters in the brain. So you get a lot of neuropsych side effects with these agents, especially in the older folks. The last are the COMT inhibitors, so these are one of the drugs that metabolizes dopamine, also norepinephrine in the central neurons. So right here. There's two of them that are on the market. These are also referred to as levodopa extenders, so you can see how that would work. They just keep them from being levodopa or dopamine from being metabolized as quickly. These are talcopone and entacapone. They're not effective used alone, so they're always going to be used in combination with these products. Let's see. Under adverse effects, tolcapone has the most of the side effects, and it has hepatotoxicity. So kind of keep that one in mind as a problematic. Diarrhea also tends to occur in about 5% of patients, and it just doesn't go away. It will be a dose-limiting side effect of the drug. The last is on page 21, just a note about low-dose estrogen. It has been found to be somewhat effective in patients who, postmenopausal women. So if you consider it as an add-on, it would never be used as a primary, but may give some improved on time in those women. Same side effects, same contraindications would all, in terms of using an estrogen and a progestin, if you have an intact uterus as well. I think that's it. Questions about those? All right, good luck in your